Hey students, this is your Professor Omelianchuk here talking to you about therapeutic misconception. Today is day 19 in our biomedical ethics class, and since it's the first day of online education, it is relevant to your studies. I just wanted to go over a little bit about how I'm going to be managing things going forward. So today's discussion questions, there's just 3 of them. You just have to answer these. They're right here under the discussions tab. Right, so check them out. You just have to answer these 3 questions after you kind of watch the video that I posted. It's going to be found here in Canvas when I'm done. Right, if you're looking for the video, it will be under here. Let's see, where are we? Day 19, yes. So I will just post it inside of this area of the Canvas page somewhere. There's the reading for today that's relevant as well. All right, and so that is what I'm just going to be wanting you to do. You don't have to respond to one another to get points for class participation. I just would like you to answer the 3 questions as best you can. And if you don't quite understand the question, that's fine too. You can say why you don't understand it. I want to be kind of lenient here about how I grade class participation, just like I am in class. Right, I'm not asking you to kind of solve the world's problems. Just participate with the material as I've kind of laid it out. All right, so also virtual office hours. You can hit me up in Zoom starting on March 23rd from 12 to 3. All right, that's going to be my office hours. I should be by my computer, barring any changes. All right, so I'm not sure what the future holds for me right now. And working with ANMED, they are putting together a plan as we speak about how to deal with scarce medical resources and be a part of ethics consultation committees. And so I'm kind of, it's day by day here. All right, so that might change, just so you know. Okay, just so you know. And for our open week, I think we're going to be talking about infectious disease and allocation of scarce resources, because that's very much my world right now. All right, so I think that is something that I want to talk about with you all because I've been learning a lot. All right, so anyway, let's get on the topic for today. Therapeutic misconception is not a problem for valid consent. And this is going to be a catch-all term. There's other things that this goes under, right? And I'll explain what I mean by that. It's not just one thing, but there's several things involved with that, okay? And so for background, okay, I want to draw your attention to this really wonderful 60 Minutes piece that was done a few years ago now. Where is it? Here it is. And I was searching. It is called Killing Cancer. All right. And it follows some patients in a Duke University trial where they are re-engineering polio, right, to kill cancer cells, right? Isn't that amazing? We had a polio epidemic so long ago that hurt and killed lots of people, and now they're trying to re-engineer it to take on cancer, okay? And it's fascinating, and I was going to have you watch some of this, but of course CBS puts everything behind a paywall, and so you cannot watch this anywhere. YouTube and everything has been scrubbed. I couldn't even get the library to get access for our class, and so instead of having you all sign up with this ridiculous streaming service, I just drew your attention to this transcript of the TV show, which makes things a little bit more awkward, but I'll try to help you navigate this page as we go along. And one of the things that's kind of interesting here is that it is a study that was in phase 1. Okay, it was a phase 1 study, and I'll talk more about what that means. Right, but one of the parts of the interview that was really interesting between Scott Pelley and the people involved in the study was this one woman named Stephanie Linscomb. All right, so she had, and you can follow actually the I might have had the link up here someplace. Yeah, I already did. And she is really interesting. She is part of the Duke Cancer Institute, and she is this young woman who is from Greenville. How do you like that? 24 years old when she was photographed here, and she had brain cancer, right? Stage 4. I don't even know how to pronounce that, brain tumor, right? I like it when medical professionals use, plain language for us, all right? And she became a part of this experimental polio virus therapy, and her cancer went into remission. Right, it's a big success story. Okay, and she's an oncology nurse now. Right, so that's what she's working on. That's what she's doing. Right, she's really kind of this happy person. If you can see the video, right, you'll get that sense. And so Scott Pelley was interviewing her, and when they showed you this picture, right, of your brain tumor, I believe here it's not that one. Let me see. This is already, yeah, here we go. Right. I think this is it. I don't know. That's just part of the video, but you can kind of see what the thing can do, right? It's pretty amazing how it can, take the tumor away, right? That's what it was doing, and this was just very experimental. Okay, it wasn't like at all close to being approved therapy. All right. And so Dr. Friedman, who is kind of the leader of this thing, was very surprised because on a phase 1 study in particular, which what Stephanie was on, you never have these kind of results. It's just so rare. All right. And that's because you're not expecting to cure people in a phase 1 trial. Phase 1 trials are not designed for any kind of benefit whatsoever. All right. Basically, what you're doing in a phase 1 study is testing for toxicity. All right, you're just trying to get the right dose. So, when people are in phase 1, right, what happens is they get increasing dosages until things, until it's too toxic for them, right? And I'll talk more about that. But you should have the 3 phases in your mind here, okay? The FDA approval requires experimental drugs to go through 3 phases. Phase 1 is all about testing for toxicology. All right. Phase 2 then determines kind of like, it's more finely tuned tests to determine the optimum dosage to get like the best effect. All right. So then you're figuring out, okay, when you write a prescription, you got to take like however many milligrams. They're working that out in phase 2. And then in phase 3, that's where you have like the big randomized control trial where you test it against a placebo, right? And so you're monitoring and comparing efficacy. You might test it against another drug, right? We talked about that last time we met. And you also are monitoring for adverse effects and side effects that you will hear then delivered in an ad, right? If it's FDA approved, you'll hear about all the side effects. And they find out all of those things in phase 3, okay? There's also a phase 4 that they talk about sometimes that pharma companies are interested in, but that's after it's approved. That usually has to do with how it's competing against other drugs. But I don't include that because that doesn't have anything to do with FDA approval. Okay? So anyway, what you have to know here is that none of these are designed to benefit the patient, right? And most of the benefits can be found in phase 2 and phase 3. So if you're wanting to be a part of a drug trial and you're kind of hoping for some benefit, you should really be looking at phase 2 and phase 3, right? Phase 1 is not where you should be looking, all right? Phase 1 promises the least amount of benefit, if any, and has been known for years to cause deep misunderstandings, right? And researchers have been known to help perpetuate them. This was a paper that I thought about assigning but did not. I just link it to it in the lecture here for your I can't find the words. For your benefit. There we go. For your understanding and education. This is a great paper. It's written by a physician investigator who just talks about how all the ways that they are able to rope patients into these things, usually under the misunderstanding that these are going to be somehow therapeutically beneficial to the research subject, right? When their design is not for that at all. Okay, it's not for that at all. All right. So the main question that I want us to consider here is, well, actually, before I get into that, I want to go over a little bit more about how these things work. I want to explain how phase 1 works and really what the problem is for ethics, right? So I pulled this from another lecture, and so that's why it's kind of funny. There's Stephanie Limscombe right there talking to Scott Pelley. Right, and so here's what's going on, right? You have to understand this lecture came from one that I did about unrealistic optimism that was mentioned in your reading today, along with therapeutic misconception and misestimation. Unrealistic optimism, though, is the one that everybody's been worrying about lately. Okay, so that's going to be a subject of the next paper as well. So I did want to dwell on it a little bit, all right? But it's recognized as a kind of cognitive bias. Okay, it's just one of these things that affects our reasoning and undermines rational decision making. And it occurs when a person believes she is more likely to experience a positive outcome than others who are similarly situated. All right, so here's some examples, right? Think about a smoker who just believes that they're not going to develop health problems. We do know that there are such people, right? You've always heard the story about your 75-year-old grandpa or grandma who smoked a pack a day, and they have some health problems, but they just kind of keep trucking along, and it's nothing really serious. And so you kind of just think, well, that'll be me too. All right, that'll be me too. Like, you're not going to develop all the other different awful comorbidities that come along with this kind of stuff. And so, that's an example. Here's another one, newlyweds, right? You think you're really special when you get married. You have this special bond, special love that's unique in the world, and you're just not going to get divorced in the first 5 years of marriage. That happens to other people who are flawed and silly. And of course, that's not true. We all know that there are statistics, right, that show that you're really at high risk of divorce in the first 7 years of marriage. All right, so after that, the numbers go down. Okay, but of course, and there might not, here's the other thing too, there might not be something wrong with having unrealistic optimism. I mean, I don't think anybody should go into their marriage just thinking, well, we got a 50-50 shot, we'll see if this works. I mean, usually you kind of want somebody who's like, I am with you, right, forever, and that's sort of that's the kind of thinking that you kind of need to have, right, to get through marriage. So I want to be kind of careful here that this optimism bias isn't always bad. All right, it isn't always bad. Okay, here's one that I think is kind of funny, right? A philosophy graduate student getting a tenure track job after completing their PhD. It's really, really rare. Okay, but I think there's one of you in the class that's interested in getting a PhD in philosophy and teaching, and just know that it's really, really hard to get a job doing this. One of the things you're gonna have to kind of keep telling yourself over and over that, well, I'm gonna be one of the lucky ones. All right, I'm gonna do this. Otherwise, it's really hard to finish a PhD. Okay. All right. And then, of course, for our purposes, phase 1 cancer trials, right? Now, I've talked about this a little bit already. They're designed to test for toxicity, right? The drugs that are selected for phase 1 are selected by virtue of the positive effects that are observed in animal subjects. All right, so you do some testing on some lab rats, and you can kind of see that, oh, this might work. Let's try it out in human beings. Okay, all right. So you don't have a lot of basis. There's no evidence at all to think, well, this is going to be beneficial. You're just trying it out, and you're trying to see how much you can give a human being before they get sick. Okay. Usually the people that participate, these are not healthy people. Okay, they are people who are cancer patients, oncology patients who have exhausted all other options, and their life expectancy is about 4 months. Right, this is the information I got out of that Matthew Miller article that I was linking to. I'm just trying to summarize it for you. Right, and so then what happens is that these people are approached by a PI after a physical and medical history and stuff to invite someone in the trial. Okay, if the patient is healthy enough to participate. Right, so they pass the inclusion criteria. And then dose toxicity measurements are gathered by successfully administering larger doses of novel agents. Okay. The trial ends for the patient when serious, though reversible toxic effects are produced. All right. So this can be ended for the patient in particular, and then as a whole. All right. Once they kind of have a good data set. Usually it involves about anywhere from 25 to 50 people, I think I've heard. Then you kind of go, okay, that's how much a human being can handle, and so then you move on to get approval for phase 2. Now, people can suffer some real adverse effects in this. We all know that chemo, drugs, and all kinds of that stuff in oncology can be pretty bad, right? But the common ones here include some hemorrhaging, severe nausea, painful throat sores, okay, that make eating difficult, if not impossible. Sometimes people got to go on feeding tubes. All right, it can be really, really, really gross. All right. If people ever experience any sort of positive response to the tumor that they have, right? This is like shrinking the tumor or affecting the tumor in the way that we would like. This will happen at about 80 to 120% of the maximum tolerable dose, okay? And so what that requires is that the patient's got to be a subject in the trial in the later stages of testing, okay? So if you're in there in the early stages, okay, you're going to be, 10, 20, 40% of the maximum tolerable dose, which they found out after the fact, okay? They find that out after the fact. Well, you're not going to experience anything. You're just going to be kind of taking a pill, right? You're not going to be pursuing any kind of palliative care or anything like that because they don't want the other agents in your system to be interrupting, okay, the effect or having some kind of confounder, right, that they're testing for, okay? This is a research trial. It's not meant for your benefit, okay? Best case scenario, which is complete remission, occurs at rates well below 1%. Now that's according to Miller, all right? Matthew Miller, the paper I just linked to, right? We obviously read some different stats in today's paper by Miller and Joffe. And so this is going to be a point of contest, right? So for those of you who are kind of data heads and empirically minded, you might be interested in looking this stuff up. Okay, what exactly is the response rate? The Miller paper that I was talking about, that I linked to, that was published in like 2000. Miller and Joffe's paper, different Millers, by the way, that was 2013. So things might have changed. Okay. All right. Among those who experience complete or partial remission, malignancy reappears in 3 to 6 months. Okay. So even if you have some really positive outcome from the trial, we all know that metastatic cancer just comes back. All right. So it's not like it's going to be any kind of cure. All right. This is why Stephanie Lipscomb's story is so amazing, is that it did go into complete remission. It's just incredibly rare. All right. So there's little chance of positive outcome and a high risk of suffering, painful discomfort. That's just basically the deal with these things. Okay. So why participate? Well, having a small chance with an unproven drug is better than no chance without it. And that's pretty reasonable. It's hard to disagree with that. Okay, I'm thinking about my philosophy PhD. I know I have a small chance of getting a really good job after graduate school. But you know what? I'll take that chance. If I don't do the PhD, then I have no chance. Okay, and guess what? It worked out for me. I got to work at Clemson. All right, that was awesome. And now I'm going on to other things. And so, look, you just gotta kind of have to just take your chances and go with them, right? And so it's rational to pursue if this is what you really deeply value, okay? But this is also where unrealistic optimism can emerge, all right? It can be potentially problematic for informed consent, right? So they measure this thing, and I don't know, this isn't super important, but usually you could compare the actual rates of benefit with reported expectations of benefit. So a smoker who has 20% chance of getting lung cancer displays the bias when she reports that she only has a 5% chance of getting lung cancer, right? You're just not really you just think the odds are in your favor for some reason, okay? And so the report is even made when one has the right information, right? They got the stats, they understand it, they comprehend it. They could report it to you on a quiz, let's say, all right? All right. Okay, so I want to hone in on a phase 1 dialogue involving Donna Clegg. This is in the Killing Cancer transcript, right? Donna Clegg met Stephanie Lipscomb and wanted to be a part of the trial, and she signed up. I think she was in her 50s or something like that, just a little bit older. And she says, "We're going to do it." Right? And Stephanie says, "Yes, high five." Obviously she knew about Stephanie's story, wanted to be a part of it. Okay. And then Donna said, "Thank you. I want to be able to live." So that's kind of how I feel. This is going to be my opportunity to have a full life. She wants to be like Stephanie, right? She wants to have the same outcome as Stephanie. Okay. So it's really, you can imagine how powerful this is, right? The story that gets told. Okay. And none of this is to say, I'm not calling into question Stephanie's research ethics here. She's excited about the trial. She knows what it is, right? She communicates what the trial is, right? That it is research, that it is phase 1, right? I'm taking her on good faith here, right? There's no reason to call her integrity into question. But I'm just trying to set up the structure here about how this might occur. The problem is that things don't work out for Donna Clegg. Okay, they don't work out. And upon reflection, what ends up happening, right, is that she gets a really high dose of whatever agent they were using to perform this, right? And what happens is that it caused such a strong immuno response in her system that it actually ended up really kind of frying things in her nervous system, and she became partially paralyzed. Right, so she actually had a very serious adverse event in the study. Okay, and so upon reflection of that, she said, "Boy, I thought this was going to be the miracle." Right, when you're told you either take this chance or die, what would you do? Now, again, right, I'm not saying that the researchers told her this, but this is sort of the message that you get as an oncology patient. It's like, this is kind of the way things are. You either take the chance, and it might things work out for you, or you don't, and you die. And so within that framework, right, like just like on the last couple slides there, you know, what would you do? That's the question that she asks, okay? Wayne, I think is her husband, she asks her, if you had to do it over again, what would you do? And Donna replies, I may not have done it. Okay, I may not have done it. Right, so you can kind of see how this could be like, is there an ethical issue here? All right, and so we might think that these biases, right, are of ethical concern because they're associated with poor knowledge and greater use of rationalization, defensive strategies, and processing information that just makes informed consent problematic. And maybe these people should be excluded because a hospice care scenario could be better. And a lot of times hospice care is better, right? People have a higher quality of life. They live longer. They die in circumstances that are just better than dying from the kind of pathologies and sickness that might come from being in a research study, all right? So the main question I want us to consider here, and this is also on the document, the Google Doc that I'll go back to, is should subjects who must misunderstand or misestimate their chances of benefit be excluded from the trial? Okay, that's what I want us to think about, all right? So I know I don't usually do PowerPoint, but since I had that handy, and it kind of explains this particular document here, right, and what's going on, and just the story about Donna Clegg, I want you to have that in the background. Okay, and I'll link to that PowerPoint if you're interested in seeing that. Okay, no problem. All right, so basically here is an argument I want to talk about in favor of exclusion. Okay, so these are just 5 premises. This is something I just kind of made up. I wrote a paper about this once, but I never pursued publication of it just because I didn't think it was very good. But I do think this is the kind of like, all right, suppose you're going to develop some exclusion criteria, give us a justification for why, right? And so here is like the argument, right? Premise 1, if a patient displays, therapeutic misunderstanding, I'll talk about that actually a little bit later, or therapeutic misestimation or unrealistic optimism in the phase 1 clinical research trial, then they fail to appreciate their situation. And if they fail to appreciate their situation, then their autonomy is cognitively impaired. And if that's impaired, then they cannot give informed consent. And of course, if you can't give that, then you ought not be a subject in the research trial. So therefore, if these biases and problems are displayed, right, in a phase 1 trial, then the subject should not be in the trial. Okay? All right. Let's talk about these a little bit. All right. So we've already talked about unrealistic optimism a bit, and I don't want to go over that anymore. Okay. But that is a species of problems that are related to these other 2, right? Therapeutic misunderstanding. Okay. The problem here is the subject just does not understand the purpose of the trial. Okay. So that's a big one. People just think, oh, this is a drug trial. Okay, this is for my benefit. The design of the study is for my benefit. And the answer is no, it is not. it is designed to give us knowledge, right? Knowledge about toxicity, okay? Therapeutic this should say misestimation. Let me fix that. There we go. Therapeutic misestimation. Right here, the subject believes they have a good chance of benefiting when they do not. All right, so look, you just might think that your chances of benefiting are really high. Okay, you're gonna get, it's like it's gonna be above 50% when it's more like below 1%. Okay, you just, you just don't seem to have the right understanding. All right, and so then unrealistic optimism, okay, you just believe that you're more likely to experience a positive outcome than those who are similarly situated. So you might know that you only have like a 1% chance of benefiting, but you just think you're going to be a part of that 1%, right? And that's where I'm going to end up, okay? And so that is also considered a problem as well. So let's talk a little bit about what informed consent usually requires. Okay, let's kind of review. We've talked about this a lot already in our research ethics unit. But these 5 components are sort of seen as, if these are in place, then you really have a good informed consent procedure going on, right? Capacity to make decision. You want the person to be voluntary. Okay, you're disclosing all the relevant information. Your subject is understanding it. And then your subject gives you an authorized decision one way or the other, okay? And refusals can be just as informed, okay? That's just fine. But usually consent involves, right, to participate, right? So maybe we'll put that in there to highlight participation and consent, all right? Well, okay, so, all right, here we are, finally to Miller and Joffe, okay? Miller is a bioethicist affiliated with NIH. He's written widely about the ethics of biomedical research and organ transplant. Full disclosure, I often take Frank Miller to task in places like my dissertation and my published works. So he's kind of a foil, but he's a very accomplished, deep thinker about all these things. Highly respected, and that's why he's with NIH. All right, Joffe is also really up there in the bioethics world. He's a pediatric oncologist, and he is also a bioethicist who has been affiliated with NIH and UPenn. All right, so both these guys are at the top of their fields and are often consulted about these things. All right. Both of them, too, are friendly. If you'll remember from the last unit we talked about, the idea of integrating research and therapy to a moderate but not radical degree, right? So that's just who they are, right, who the authors are. And so let's kind of get into their paper here, okay? So here we have their central argument, and for whatever reason, the numbering doesn't make any sense. Google Docs, come on. There we go. All right, so look, I think this is what I take to be, I guess, the central argument and what they're up to here is that the first premise is that there's no consensus about what subjects must understand or appreciate in order to give valid consent. Right? Just to kind of go over this, understanding is sometimes distinguished from appreciation. Right? Understanding is like, okay, are you understanding what I'm saying to you? Right? Can you repeat the information back to me? All right, and so that is like one piece that's more of like a comprehension idea, whereas appreciation is like, are you able to formulate correct beliefs about the information that you understand, that you're repeating back to me? Okay, that's a distinction you should be aware of. All right, and so a lot of these times these things get conflated. Right, but that's why I put them in there, okay, is that sometimes they are distinguished. I think you could probably put all of that under understanding if you wanted to, but I just wanted to be clear about that, okay? So there's no consensus about what subjects must understand or appreciate in order to give valid consent, right? And so they talk a little bit about what valid consent is, and we'll talk about that below. Okay, so if that's so, then there's no good reason to believe the subject's autonomy is impaired. So there's no good reason to think so. Okay, so what that does then is that undermines premise 2 of the exclusion argument that I gave up here. Okay, if they fail to appreciate their situation, then their autonomy is cognitively impaired. All right, so that is sort of like what we're trying to say here. All right, it's like, look, autonomy is going to be something that can still be there, even though you're operating and thinking under these misunderstandings, misestimation, and bias. Okay. All right. So central claims of the paper: informed consent. Right? Is it distinct from valid consent? Right? So they distinguish between informed consent and valid consent. Isn't that interesting? Okay. And the reason why is because they conceive of the former, that is informed consent, to be a kind of rational ideal, right? That's what we're aspiring to, right? That's what we'd like for the patient to have, right? That is something that we're aiming at. But in the real world, where things are messy and people misunderstand things and we operate under heuristics and biases, okay, valid consent is the best we can do. All right, and that will function as a kind of minimal threshold for permissible interpersonal conduct. Okay. All right, so this is going to get tricky now, because where exactly is that threshold going to be drawn? Where's that line going to be drawn? Okay. Well, here's why they make this distinction. Okay, they know that, look, bias-free understanding is just totally unrealistic. We cannot expect even people under the best circumstances, right, to be free of cognitive biases and misunderstandings, right? So for those of you who are into psychology, you probably have come across this book here, Thinking Fast and Slow by Daniel Kahneman. Right, he's this Nobel Prize winner in economics, and he has just detailed tons of these things, right? You have all kinds of stuff, right, that he gets into. We could probably talk about this. You know, you have, oh my gosh, yeah, it's just unreal. You have like anchoring biases. You have all kinds of framing biases. He goes over like tons of them, and this is a widely cited book that gets into all of that stuff and how we just never make very good decisions, especially when it comes to like probability judgments. We just really don't know how to do them very well. Okay, even people who are highly educated and know what they're doing can make easy and silly mistakes. All right, so they think then, even though that this is the case, right, we can still give valid consent because they think that personal autonomy is durable, right? And it's durable to the degree that one is fairly, all right, given the opportunity to act according to one's values, right? So you're giving a fair opportunity, you know, and your personal autonomy can be durable even under confusion. All right, so that's the kind of the big idea here. All right, and you might think about that. What really is that possible? Okay, so that's like one thing here that we kind of have to worry about. But they kind of set the possibilities question aside and say, hey, we got to operate in the real world. Okay, and so fair opportunity is what we need, right, in order to act according to one's wishes. All right. Phase one, as we said, right, it offers, well, if they offered no benefit at all, they admit this, right? This is like their second claim. They admit that if phase one trials offered no benefit whatsoever, right, then participation in them would be contrary to the values of those who hope to benefit. Right, so the values of those, right, who hope to benefit is that they want to benefit and get better, okay? And so if it doesn't offer that at all, well, now we have a problem, okay? Now we have a problem. But, and according to their reading of the statistics and the studies, they think that tumor response rates occur between 4 and 10%. I'm not entirely sure what that means. I'm not sure, you know, how big these response rates are. It's unclear. Okay, you can follow their citations though, and you can read more about them if you'd like. Right, but that's what they think. Okay, they also dismiss the claims of critics who say that research design is sufficient to assert that phase one trials offer no benefit whatsoever. Okay, so I presented a paper about this a while ago, it was years ago now, And I was kind of talking about how whether or not autonomy is something that can last under the cognitive bias issue. And one of the audience members just said, "Well, look, I wouldn't enroll anyone who in one of these things because these things offer no benefit." Right, and following up with her, I asked why. It's because they're designed. They're just designed to go for knowledge. Okay, so you can't say that they offer any benefit. It's just like, so she was very much kind of operating under that distinction between research and therapy that we talked about last time. All right, and just out of that principle, you can't say that they offer any benefit. There's no real scientific evidence for that. Okay. Because it's structurally somehow called into question just by virtue of the stage of science we're at, what kind of study design. It's just in virtue of the study design, right? And they reject that. They think that they call fallacy. They don't think that follows, right? And they also think that since they offer some amount of benefit, right, this between 4 and 10% thing, then people who hope for some benefit can autonomously choose to participate. What's kind of interesting about this, though, is the way they frame it, right? What if they said, well, they have a failure rate of 90 to 96%, right? How does that make you feel? Do you want to sign up? Right? That's part of the story here, is how you frame things, right? And if you say, well, they have a failure rate of 96 to 90% or something like that, that might actually shoo people away. But if you frame it like this, oh well, I'll take that chance. Again, this is how we operate as human beings, and so at any rate, right? They think that that's enough to allow people, right, who hope for some benefit to autonomously choose to participate. Okay, autonomously choose to participate. All right, capacity, they think, is more important for valid consent than understanding. Right, so if we go back up here, right, to these things, capacity in their view is weighted a lot more. All right, so yeah, understanding is what we aspire to. We want our patients to understand things and appreciate their circumstances. But if they don't, if they don't really understand, and yet they still have the capacity to make the decision, right? Well, we ought to respect that capacity. Okay, that's what they're saying. Okay, so even though they might have misunderstanding about the evidence for possible benefit, right? We want to be able to respect their autonomy, right? And that's important. They think that there would be a disrespect of that capacity if we were to say, well, you just don't understand, so you're not a part of this. Okay, that bumps up into the autonomous choice issue here that we've been talking about these last few weeks. They also say that what we know about these participants individually, right, leads them to believe that that many would still participate even if they had perfect understanding. All right, so if you can control for that, right? Suppose that they had perfect understanding, they're still going to go for it, right? They're still going to take the deal. I'll take my chances with the 4%, okay, rather than no percent. And they don't think that makes any kind of presumption about what they would consent to under ideal circumstances. All right, there's not like a presumed consent going on here. That's what I mean by that. All right, it's just kind of like from their experience, right? That people are motivated by this kind of reasoning. All right, that's what's kind of going on here. Right, I hope that makes sense. They're not being presumptuous, right? They're actually going by the evidence, what they observe about people's motives. All right. Okay, wow. So we got to about 40 minutes here. I try, my goal is to make these about a half an hour, but it's just the way it goes. All right. So again, here I'm wanting you to just reflect on these questions, right? In light of this information, what did you think? Right? Think about the 60 Minutes piece, right? How do you feel about Donna Clegg, all right, who became partially paralyzed because of the higher dose in the study. You can go back to it and read it here. I encourage you to do that, right? It's if you don't know how, oops, that's my music. Where did the study go? Well, I guess I must have closed it. Oh, there it is. Okay. If you just do like a Control F on your computer, right, and you type in Donna Clegg, there her name comes up, and you can read about how she feels and how things worked out for her. All right, and how her researchers responded. It's really kind of interesting, right? And do you think that she should have been able to? I don't know. Should she have had more? Did she have a fair opportunity? Right? Did she have a fair opportunity? Do you think that she? I don't know. Just how did it make you feel? Basically, it's all I really want to know. Okay. How did that make you feel? That story. And do you think that this take this chance or die framework that Donna adopted is one that is problematic for autonomy? Okay. And why or why not? And then do you agree with the authors that we should distinguish between informed and valid consent? Right? If not, why not? And if so, do you think where they draw the line for their minimal threshold of permissibility is the right one? All right, so that is today's lecture. All right, if you have questions, just email me. I'm perfectly okay with that. You can hit me up in the office hours when we meet again. I think the meeting time will be available to you if you click on it. Right, Zoom is something I think that is just really easy to use. It makes you download an app, and you're then all good. Okay. All right, so that is today's lecture, and I will talk to you later.